Hey, gang, it is Wednesday. I've been off for 2 weeks, fresh off of the Rock Legends cruise. And then last week, the American Equilibration Society, the Chicago Midwinter Dental meeting, and the Restorative Academy meeting. So it's been about 2 weeks away from the office and 2 weeks away from just being in normal routines. But man, glad to be back with you. This is Dentists in the Know. This is our Hump Day Happy Hour. And this is your backstage pass to current trends, politics, and education in the dental world. It's live, and tonight it's over a mixed beverage. Usually, I'm doing the wine thing, but it's been that kind of a couple of days where I thought I deserved a mixed toddy. As you know, I do this show with some of my best friends in the entire world, Dr. Jennifer Bell and Dr. Chad Duplantis. We are all practicing dentists. We are all business owners, and we are all educators. And guess what our job is? Do you guys know what our job is?
To
bring all of you in the know. In the know. Hey, guys. Long time no see.
Long time no see.
Yeah, we spent a lot of time.
Could totally get used to seeing you guys every single day.
We did have a fun time.
I think there's a term for when the two of us, at least these two are together. It's kind of a shit show.
It was like a kid in a candy store.
Yeah. We did have a great time though, and we got to see so many of our close friends and so many people that we've had the chance to interview and lecture with and learn with and go to school with. And it really is one of my favorite weeks of the year, not just because of the technology that we see, not just because of the education that we get, but really just being with so many other like-minded people, like our guest tonight, who's probably one of my favorite dentists in the whole world, other than you two.
Obviously.
But
we obviously compare to our guest tonight. As I learned this weekend, I'm a pretty humble person, but when you sit in a room of giants, you become very re-engaged with your own humility a bit. And then like all day today and yesterday, I'm replaying all the stuff that I learned and looking at my dentistry and going, it's just shit.
It's so funny. Do you know, for the last 2 days, all I could think about was how meticulous that tunnel grafting lecture was, how meticulous that surgery was, thinking, I don't think I ever friggin' had hands like that.
No.
This guy was a genius, this guy. And but we saw so many people like that. So real quick, Chad, first, what was your highlight of the week?
Obviously, my highlight was spending time with you two. And I mean that from the bottom of my heart. I think we had a fantastic time. We met with some incredible educational partners. It was just a great weekend. I mean, there was a rat race that's just the name of the game. But it was a fun rat race, and there's no other people that I'd rather do it with. But I'd also have to say that receiving the Cuspy Award and seeing that people are actually appreciating what we do, thank you. It was amazing. It was amazing.
Awesome.
And
I mean, what was your highlight?
Go ahead, Chad. Finish your thought.
I was just going to say AARD was amazing because I was with you guys too, but the education, just if you've ever not been, find a way to go. It is, oh my gosh, amazing education.
I concur with all of Chad's highlights. I also would say,
Doctor, do you concur?
I concur. I agree. Seeing snow, like the perfect amount of snow where it was beautiful and made the roads a little slick for Chad, but otherwise very beautiful. Being a student when Dr. Coyce was being a student, like those are fangirl moments where you're like, oh my gosh, we're both being students at the same time, instead of usually the inverse relationship where I'm the student and he's the lecturer, and Spear and all the other folks that were in the room are folks that you've watched and learned from for years. So that was very pretty awesome. And I met so many interesting people. And what I have to say, probably one of the most impactful comments, maybe she'll listen to this show, but Ellen Katz and I were talking, and she'd actually mentioned it to Chad as well. But, someone who came up, and I knew her, and we've kind of circled around similar groups of people, but she said, I feel like you are my friends. I listen to you when I have the long drive into the city, because I have 2 practices and I have a second practice in New York. And I listen to you on my long commute, and I just really enjoy it. I feel like we know each other, and you don't realize the circle or the ripple that you're making outside of just bringing people in the dental community to the forefront for folks to listen to and learn from, just like we're learning every Wednesday. So those were big moments for me.
Yeah, I couldn't agree with what both of you have said more. I mean, to not only listen to some of the people that we got to listen to and watch their work and watch their passion and say, you know what, I thought I was pretty passionate about my work, but they put every bit of their heart and soul into this presentation, into what they're doing and their contributions to our profession. But it's exactly what you said, to be able to sit with the likes of John Coyce, of Jim McKee, of Jeff Rouse, and actually bounce the ideas off of other clinicians like that. It is just, what a great experience. And honestly, I have to tell all of you, whether it's just going to the Midwinter meeting, which there's so much to do there. There's obviously a lot of great lecturers at that meeting, but I always start the week out with Equilibration Society, try to end it with Restorative Academy. And it's a lot. I mean, honestly, you can get overwhelmed with that amount of time. But it ends up being so inspirational. But I think the other highlight was the other thing that you mentioned. One, Chad, what you said about getting the Cuspy. I know, whatever your thoughts are about these kind of dental awards, it was very, very special because it was actually the listeners and the readers that voted on that. So that meant a lot. To have several of our really esteemed colleagues say, thank you for what you do, right? That was probably the best part of the weekend, really, because that just validates what we're trying to do, and that people are understanding what we're trying to do, and just bring the dental community forward. But what a fun ride, and I love being on this ride with you guys.
Couldn't
now
agree
we have
more.
to plan our next trip. I'm ready.
Yeah.
We're
warmer.
I'm thinking that it might be. Well, there hopefully be something before then, but
Nepal.
A little bird told me that maybe in October you might see some people presenting from the stage in a podcast format at a thing called SmileCon.
Oh, maybe.
Oh, that could happen.
I don't know.
All right. Well, stay tuned, because and then also a little birdie told me that there's an organization called ADA, which is the American Independent Dental Alliance, that's going to be doing a lot of education, advancing many of the dentists that want to stay independent, and working with several of the dental manufacturers that want to stay independent. And I think you're going to be seeing a lot of our smiling faces at that as well. So it's fun. I'm so excited to be doing this with you guys. And we say that all the time, and not patting ourselves on the shoulder. Really just thankful to all of you who appreciate what we're doing, because we're having fun doing it. So
absolutely.
Yeah. With that said, JB, we have to probably do a little bit of work here. Were you able to get some news in that short week?
Yes. Well, I didn't do it last week, and I'm sure the viewers really felt the absence. And at their kitchen table, not having anything to discuss. They feel very out of the know. So we're going to solve that problem.
It's like a blank TV at 6 p.m. What do you do?
I don't know. I don't know.
Yeah.
I don't know.
Great. Now how am I going to get my news? All right, do it, JB.
All right. Well, we have some really interesting stories. I'm going to start with the heaviest first because the guys always give me a really hard time about doing super sad stories and leaving a big, black cloud hanging over the rest of the show. So let's talk about the hardest one of the bunch first, and then we'll get into a little bit more light news for the week. I think it's really important, though, because I've seen several posts over the last probably year of dentists who commit suicide or take their own lives, periodically through different forums. Dental Nachos has posted several that have been out there that, you wish as a colleague you could lean in and have loved on to maybe keep them from making that choice. But an interesting study that just came out from the Community Dentistry and Oral Epidemiology Journal noted that nearly 20% of dental professionals have considered suicide in the last year. So that's a pretty significant statistic, that certainly we need to be paying attention to and ensuring that we're providing mental health and support to those who need it. But I would also, this is going to be my my plug or opportunity to speak my mind for a moment, as this is more of an editorial instead of a factual news program. But to maybe stop stigmatizing a lot of the different ways in which people practice and really created an open community where folks can be in corporate dentistry, can be in private practice dentistry, can be PPO and fee for service, can only treat children, only treat adults, can really build the life that they envision for themselves. That is the perfect balance for them between work and their personal family life. And so when we can start breaking down some of those barriers to create a more welcoming environment to practice and be the kind of dentist that you feel most comfortable being, I really hope and pray that that will be one step towards helping some of the mental health issues that we certainly see in our profession and continue. So we'll leave it at that. Let's move to a little bit of a lighter story. In fact, I had to read this story about 4 times in order to be able to bring it to you tonight, because I just couldn't believe it. Also couldn't quite get my mind wrapped around it. But there is a dentist in Tampa who is trying to compete for the world record for being able to pull his 2,000-pound car, we'll mention it's a Lotus, with his teeth, 30 meters in a specific amount of speed. So he can be the fastest to pull it. The record is just over 18 seconds. So he's working towards that. He does, in fact, have a solid titanium jaw or metal, steel jaw. And he has other oddities as well. He's been featured in Ripley's Believe It or Not on multiple occasions. He has a complete denture made of shark teeth and one with a cyanide pill, just like you found in the James Bond movie. So this is an interesting fella. We'll be tracking his progress. If he beats the world record, that certainly will be newsworthy. But here is an example of dentists finding ways to unload the pressure of our daily activities and things that they enjoy. But certainly an interesting activity and hobby, slightly different from gardening and baking and racing cars, which are some of the other things that we hear dentists doing. Another interesting story actually came out of Texas. So I thought Chad might find this one interesting. A whistleblower has now, the Texas dentist has now been charged to pay back $15,000 in a whistleblower case on COVID-19 safety concerns the employee raised and was terminated or discriminated amongst their fellow colleagues. And the case has been settled, and that employee has won a $15,000 settlement. So just remember, when we're making decisions in our practice, to try to make them non-discriminatory and wide encompassing, so that in the event that those folks leave your practice, that it may not financially come back to bite you. Here's an interesting one. I'm curious to know, when we get back with the guys, how much they received from the tooth fairy when they lost a tooth back in their youth, assuming that they're no longer that young. An interesting statistic has come out. There's a group, the original Tooth Fairy poll, which started its data collection back in 1998, has noted that the cost for a tooth has jumped 16%. So Tooth Fairy is no stranger to the rate of inflation as well. We are now up to an average cost of $6.23 per tooth. That is up from $5.36 in 2022. Now, I have to tell you that the South, which all three of us happen to technically live in, had the highest value per tooth at $6.59, while the West was second at $6.25, the Northeast at $6.14, and the Midwest coming in at a solid $5.63. Still seems crazy high, but there you are. In case you're wanting to calibrate, am I in line with the current Tooth Fairy rates? Now you're in the know. And the last story for tonight, the ADA Standards Committee has been incredibly busy over the last year working on several initiatives. They just released their white paper on AI. So if you have any interest, it's a pretty heavy paper. They have been very intentional about collecting, evaluating, and determining AI's role in dentistry. And so it's a pretty encompassing paper on AI and AI standards in the dental field. So I would encourage you to read it. I certainly would encourage you to review it if you're considering bringing AI into your practice or wanting to be more involved in that area. But in addition, the ADA Standards Committee is looking to start another group, a subcommittee within their group, looking at standardizing how we obtain information about dental benefits from insurance providers. I actually happen to think this is a great idea, to be able to reach out to providers or insurance carriers and get a consolidated piece of information about benefit in one concise form without having to ask each individual question, or maybe getting certain information from certain carriers and being unable to obtain the same types of information from others. So they're looking at standardizing our ability to verify and quantify benefits for patients, and especially in light of the new laws out there that are for surprise billing and ensuring that you're not surprising patients with bills over $400. It only seems fair that we should be standardizing how practices are able to get their benefit information and provide good faith estimates to their patients. And with that, that's the news.
Please allow me to just take a minute to introduce really just an incredible guy, a true friend and mentor in dentistry. I got to know him when I was studying at the Piper Clinic and in the Piper Study Club, and Jim helped run that at one point. And you know, he's just such a boots on the ground kind of dentist. And you know, where a lot of times at the Piper Center, sometimes some of these concepts were really kind of out there, especially coming from some of the training that I had and trying to reconcile some of my old training and this new way of thinking. You know, a lot of times it just came down to, let's have a beer and talk, Jim, or can I call you and can you look at my scan and let's talk some real world dentistry, because my brain isn't quite as big as Mark Piper's. So I need to see, how do we really put this together? And Jim he's an amazing teacher, as I said, an amazing friend. He's now resident faculty at Spear. He runs his own study club at TMJ. He has a practice in Downers Grove, Illinois, in the Chicagoland area. And I am so happy to have our great friend, Jim McKee, back on the show. How you doing, Jim?
I'm wonderful, Jeff. I'm terribly humbled by your very nice introduction. Thank you so much. It's great to be back on with you guys.
Yeah, put the check in the mail, please.
I already sent it off.
Well, Jim's going to talk to us today about pops and clicks, which I'm going to try not to interfere too much, but this is really hard when we talk about sleep or TMJ or any of these functional issues for me to keep my mouth shut. But what I'd really like to do is to allow...
I don't think I've ever seen that happen, Jeff.
Yeah, I know. I'm sorry. Well, why don't we do this? I'm going to toss it over to you, Jim. And then I'd really like, because I love the title that you put out there, Pops and Clicks. How many of our patients come in with that? Like all of them, right? Like, you know, a very high majority of our patients have had what they have called TMJ symptoms or have pops or clicks. Are they innocent? Is it something we should be paying attention to? So I think this is going to be really great information for all of you out there who are watching or in the future listening. So Jim, tell us what the inspiration for that title is. Obviously, you know, I think you put on a program with that title. What's the inspiration for the title? And just give us some background.
Well, you know, the title kind of comes from questions that I had when I was a young dentist. Because I would see patients who would come in and they would click and pop, and some of them had no problems, and some had pretty significant problems. And I couldn't really tell the difference between which ones I should be concerned about or which ones I shouldn't even think about. Besides that, I had no idea what to do with them. You know, I mean, we were told to make splints. Splints would help sometimes. Splints wouldn't help a lot of the time, though. But these were in the early years, and I kind of plugged along. And then I met Pete Dawson. And Pete Dawson was really the first dentist who started to put the pieces together for me in terms of how the teeth relate to the joints. Because that was a concept that I had really no thinking about. I was basically a tooth-based dentist. And when I started to make that connection, it seems like the restorative dentistry got a little more predictable. So dentistry became a little bit more fun. You know, you talked about the problems that dentists have with mental health issues in the beginning of the show. This is a hard profession. Mm-hmm. And I really have to credit Pete and Mark Piper and the guys that really took some of the mystery out of it. And I guess that's kind of how this title came about, is because what I'm hoping to do is take some of the mystery out of that, because really there's a very logical way to think about this. You know, it seems like we've never been able to kind of put our hands around this and understand it. And as a result, we basically just push it away. So if we can understand which are the ones that maybe we should think about, or which are the ones that we don't really have to be as concerned about, then what it does, if we borrow something from John Coyce, it allows us now to start risk profiling. Mm-hmm. Is this a green case? Is this a yellow case? Is this a red case? And all of a sudden now my restorative decisions become a little more predictable, because if I have a foundation that's compromised at the back end of the system, I can start to tell the patient that we may have issues at the front end of the system. So ultimately, when we talk about clicks and pops, I think the first thing to understand is that a joint clicks. There's two reasons a joint will click. The first one, and this is the outlier, is when something opens really, really, really wide and they click at like 45, 48 millimeters. And really what they're doing is they're coming off the eminence and they're subluxing their joints. That happens, but it's a pretty rare occurrence. Let's put that to the side. The rest of the clicks and pops that we all see every day are the result of a ligament injury. So the first domino that falls in this discussion is a soft tissue domino. And when the ligaments start to come off, does it come off on both sides? Is it a complete discal herniation? Or is it a partial herniation? Now, our training, if we go back and listen to the literature, talks about a disc displacement with reduction or a disc displacement without reduction. But it doesn't talk about where the dislocation occurs. Does that make sense? Mm-hmm. So if we look at anatomy, really, I've really started to think more about occlusion as really about force distribution than anything. The muscles are positioned between the teeth and the joints. Force is distributed between the teeth and the joints. At the tooth end, We try and have even contact all the way around. And we try to make sure the front teeth contact and the back teeth separate. That's what we've always been taught. We're going to come back to that concept in a little bit and say there are some cases where maybe it might not be a bad idea to rethink that concept. But for now, let's assume that. So at the joint end, basically now we want a soft tissue disc to protect the bone when the load's applied at the joint end. If the disc is there, we can pretty much do anything we want. If the disc is there, here's the other thing. The likelihood of us having a malocclusion decreases. On the other hand, if the disc is not there, then we have the potential for a change in vertical dimension at the joint level. And interestingly enough, when we talk about vertical dimension, it's almost always talked about at the tooth level, right? Vertical dimension at the joint level is comprised of soft tissue disc support and then any bony changes you may see. So if we lose the disc, it's approximately 2 millimeters. If the condyle moves up, the lower anterior teeth move back, and all of a sudden now the class 1 patient is really the class 2 patient if you put them on an anterior deprogrammer, if you put them on a Lucia jig, if you do by manual. Now, if we don't check it, we're assuming that it's a class 1 occlusion. Mm-hmm. Now, whether that patient clicks or pops really isn't the issue, because so many times what will happen is sometimes they'll click, but not for very long. So when we talk about clicks or pops, let's try to organize it into, is it clicking or popping at the lateral pole, or is it clicking and popping at the medial pole? So that would be the first decision tree. And if the patient comes in with a history of a 60-year-old man who's clicked for 30 years, doesn't have any bite discrepancies, that all points to a disc displacement at the lateral pole, with the medial pole still maintaining the vertical dimension and the load-bearing abilities. Does that make sense? So if I hear that history, I'm thinking not a big deal. Okay? But the issue is we tend to make it about pain. I think we can get more out of looking at the bite and understanding the history, because pain's a misnomer. Let's go to the 12-year-old female now who comes in with the class 2 and is clicking. You know, the problem is they generally don't hurt till they get into their teen years. Mm-hmm. So if we make it about pain, we miss the early cases. The clicks that matter really a lot to me are in the growing patients. Jeff Rouse says kids shouldn't snore. I'm going to tell you kids shouldn't click. If a growing patient is clicking, it should warrant further investigation. And the easiest screening tool we have, as Mark Piper talked about, Jeff, for years when you and I were together with him, is simply looking at the occlusion when the joint's in a fully seated position. You'll notice I didn't say centric relation because that implies that a disc is there.
Right.
All we're doing is we're checking the bite from a skeletal position. And if we're uncoupled greater than the thickness of the disc, 2 millimeters, the likelihood increases that we've lost the disc at the medial pole. Now, that may be someone who doesn't hurt and is clicking, but to me, that's a far more long-term serious problem than the 60-year-old guy who's been clicking for 35 years with no problems. And I think that's where we get hung up in dentistry, because we see some people have clicks that don't have any problems, the other people that clicks that do have problems. And unless really we can look at the anatomy, most of us can't unless we image. We don't know what to tell the title came from, and try and understand the clicks and the pops that we may need to be thinking more about. Now, to further tie that to airway, here's the connection between those. Ultimately, the earlier the disc comes off in life, the more likely we are to have an interruption of growth in the mandible, but not only the mandible, and this doesn't get talked enough about, in my opinion, the maxilla as well. We've made joints about the mandible. Not true. If you look at the research, if you look at clinical CT scans, the maxilla doesn't project as well on the injured side. So I don't think the joint problem is restricted to mandibular development. I think it's the whole side that is having a problem developing. And, you know, Jeff Rouse and I did a webinar, are we treating the same patient? Because really what's happening is Jeff came at it from the airway perspective, I came at it from the joint perspective, and ultimately meet in the middle. And what you find out is that most of these patients have both things going on. You know what I mean?
I think you said two really important things, Jim, that I'd like for all of our listeners and viewers to really take hold of. And from a clinical perspective, the first thing that you said is that one of the first things that you will notice in someone with some type of a joint discrepancy is going to be a malocclusion that maybe can't otherwise be explained, or a malocclusion that exists that is a greater thickness or greater distance than the thickness of the disc. So when you see these large class 2s, when you see a class 2 on one side, class 1 on the other, uneven growth, things like that, that should really be a telltale sign to you that, hey, maybe this is not a bite problem, but really a foundational problem. The second thing that you said that I think is so important is how we need to be catching this in kids while they're growing and before adolescence, ideally, is the time to catch these kids. So this thought process of don't get into interceptive. Ortho, I've heard the argument all different ways. We need to be catching these joint discrepancies and airway discrepancies at or before adolescence. As soon as you see that interruption in growth, as soon as you see that change in skeletal pattern, the change in occlusion, or start hearing the noises in a growing child, we really need to intervene. I wanted to make sure that the listeners really took that away, because it's just such a key point to what you're saying.
Go ahead, Jennifer. I'm sorry.
Well, I was going to say, can we dive into that more about what, if we have pediatric patients that come in, we identify a pop, a click, or some type of malocclusion or skeletal asymmetries. As a general practitioner, what's my algorithm now to diagnose, to refer, to evaluate? Where do I go from here? It's not my area of expertise, and I don't have a Piper doctor somewhere in my close proximity. So what do I do to help these patients?
Well, the easiest thing to help the patients, I heard something a long time stuck with me. I can't remember where I heard it. Examination, diagnosis, treatment. And we kind of jump to treatment because we want to fix and help people. They need a diagnosis first. So someone has to look at the anatomy to make decisions about treatment. Whether that's you, whether that's someone in your community, whether they have to travel to get that, which is less desirable, someone has to do it. Now, my strong advice, especially to dentists who are looking to build a practice, this is by far the fastest way to build a high quality practice and bring patients into your practice who are looking for answers. You had talked before about fee for service, who are willing to have a fee for service fee structure. And I will tell you that most of the time, if restorative work needs to be done, the dentist doesn't want to do it. So from a practice management perspective, if we can learn to diagnose these types of cases, buckle up, because there's going to be a lot of patients calling your practice. But in answer to your question about the 12-year-old, someone has to do it. The problem is usually what we do is we ship them off to the orthodontist. And to be completely honest, what we're doing is we're setting up the orthodontist for failure.
Mm-hmm.
I mean, that's not their practice model to all of a sudden now bring someone in to diagnose joints, because then if they do that, they're going to have to charge for it. Then they're that much more expensive than the average orthodontist down the street from them. And that gets into a big practice management issue for them. My suggestion is that diagnostic work be done in the restorative dentist office before the referral is made. You know, think about it. The orthodontist is only going to see the patient for 2 years if they're growing. You know, I see patients who had ortho 25 years ago that I'm still taking care of problems that I missed when I was early, and the orthodontist missed them too. Most of them were class 2s, to be honest with you. So I'm thinking back, if I had it to do over again, I would have diagnosed the cases and then sent them to the orthodontist. So I don't know how to answer your question exactly in terms of what your algorithm is, but I think the first algorithm step is to decide whether to image or not image.
Yeah.
That's the first fork in the road. So if generally most joint situations will present one of 2 ways. Something hurts or something doesn't fit. It's pretty much it. And the something doesn't fit is usually the class 2 occlusion, the asymmetric mandible, something skeletally or dentally doesn't fit. And that's almost always because the disc came off, growth was interrupted, and now the front end doesn't fit. So imaging, I always say imaging shall set you free, because once you see the anatomy, there's no discussion anymore. And it becomes such a benefit for the dentist in your community to have someone you like that. Because before now, the orthodontist, when the next orthodontist, class 2 patient the orthodontist gets, guess what they're doing?
Mm-hmm.
Someone needs to diagnose those cases. So if you diagnose the 12-year-old, then the question becomes, what do you do? So one of the parts of the diagnosis is the MRI. And one of the advantages of MRI, especially in a growing patient, it has no radiation. So we can take it at multiple positions and evaluate how the disc fits on the bone. So we'll take it in fully seated. If it fits there, that's a normal joint. You can build the occlusion there. If it doesn't, but then it fits at maximum intercuspation, then maybe the 12-year-old is sent to the orthodontist with the instructions of don't seat the joints, build an MIP. If it doesn't fit an MIP, but it does in a class 1 canine position where you might build a functional, you can send it now to the orthodontist and say, okay, let's try a functional here. We've got a displaced disc, but if we can get back underneath there at this position and hold it, let's see how growth does. No promises, but at least we're in the ballpark. If it doesn't, it incise a ledge, but finally when you open it does, you're not going to build it all the way open, so then you're going to have a decision. The next fork in the road there is, do we live off the disc, or do I do something at the joint level to change the anatomy of the disc, meaning either repair the disc or replace the disc? And that walks through basically the treatment planning discussion. That's assuming the hard tissue is still good. You know, the problem in the growing patient, the 12-year-old you mentioned, is that many times those ramus lengths become short, and instead of growing out to 65 millimeters, there may be 52, 53. Those are the real retrognathic maxillas that then come to see Dr. Horowitz because they have sleep issues, because they're not projected out far enough, and they've got the collapsed airway and they didn't ground the maxillary. So now they have a deviated septum. So they have airflow limitations at the front end, in the middle, and they've got joint issues. That's the case. You know what I mean?
Yeah, absolutely.
That's
the hard part in the pediatric patient too, at least I found with sleep even, is if it's not symptomatic or, you know, It's getting the patients to buy in to the need for treatment before it becomes the problem, as opposed to being reactionary once it becomes a problem. And that, that's for another day, another topic on how we motivate patients to seek treatment. But, that's always.
I think we have to make them understand that when you're calling treatment, I'm calling diagnosis.
Yeah, fair.
That if we don't get diagnosis, all I can do is guess.
Yeah.
You know what I mean? And I'll do the best I can guessing, but it's a guess. And if that, I think, helps them move off the needle a little bit.
Yeah.
And you made another great point too, Jim, is that, one of the important parts, you said exam, diagnosis, treatment. And when it comes to the TMJ, we just can't see those soft tissue structures without an MRI. And it's incredible how, whether it's in our training or it's just, what we think of as compassion and thinking about our patients' pocketbooks. Oh, why would I make them do an MRI? That's $1,000 or $1,200. And how often have we heard that from other colleagues, right? That have said, you don't need an MRI, get a CBCT, which can give us an idea about what the disc has done, but it certainly can't tell us anything about the condition of the disc, or whether it's, medial or whether it's out to the lateral. And so I think one of the mindsets that we need to get over in dentistry is that we need to do whatever tests we need to do to get to that accurate diagnosis before we get to treatment. And really doing something like this and making a diagnosis. The occlusion is the first hint. The exam, the history are all great hints. But really it's that MRI that tells us, where is that disc living, in different condylar positions. And then we need that to make that next decision.
Two things. First of all, there were clicking joints that didn't hurt, so therefore they didn't need to be imaged, because we made this about pain.
Right.
Mark Piper said a long time ago, it's not about pain, it's about structure. It's not about pain, it's about structure. Occlusion starts at the joint level. The teeth are just along for the ride.
Mm-hmm.
The second thing is, as it said, MRIs won't change your treatment plan. We just talked about a 12-year-old that had different treatment plans based upon her disc position. Here's the other thing. On a CBCT in a growing patient, you're going to miss it because you won't see the bone defect.
Right.
Because generally they don't have that yet. Now, they may not be growing well, but you might be able to pick that up.
Yeah.
Here's the other thing. Most CBCTs are taken in maximum intercuspation.
That's the other point, is what position were they in? Exactly.
So the CBCT, if you want to try to assess disc position from a CBCT, it's best if the CBCT is taken in a fully seated position. That will allow you to see if the if the condyle is posterior, then you infer that the disc is anterior.
How do you recommend ensuring that they're in a fully seated position prior to taking the CBCT?
We send them, Chad, with 3 bite records.
Okay.
And it's just a little AccuFlow injectable bite record in fully seated, in edge to edge, or class 1 if it's a growing patient, where you'd build a functional, and then open with a styrofoam bite block. And basically they're just mouth props.
Okay.
And that's how we send it.
So I do
Jim,
have a question.
Excuse me one second, Chad. I think
go
Chad
ahead,
was
Jeff,
asking
whatever.
about, for the CBCT, how do you make sure that they're in fully seated condylar position for the CBCT?
Same thing with the bite record.
Okay.
The bite record, it's taken to the initial point of contact, and then it's held.
So you're doing that. You're making sure that they're in that's fully seated position. taking a bite registration and sending them for the CBCT with a bite registration at that position.
Exactly.
Right. One of the things I'd like to ask you, and you could send it if you don't mind doing so
Sure.
to Jeff and JB and I just via email. I would love to see kind of a referral for an MRI, because we all know that an MRI is going to be great, but I don't send out for MRIs. I'd love to.
Sure.
And that's what I tell patients all the time. I'm not going to be able to see the full picture without an MRI. I usually send them to the local TMJ guy, but I'd love to be able to send these off and then send that imaging with them.
And basically, I'll tell you, it's the protocol that Mark Piper put together is what I'm going to send. I've made a couple tweaks in it to try to see the disc better for my radiologist. But it's an easy protocol to use. My suggestion, if you're going to start to think about getting into imaging, is find a radiologist who's going to be part of your interdisciplinary team. Think of it same as an orthodontist. Think of it same as a periodontist. Find someone who you can learn with and review cases with. Here's the reality: they're not going to know as much as you will. Mm-hmm. They don't have training in this, so that's part of the issue. You just have to know that going in. But I will be happy to send that out, and I'll send you a picture too of those bite records.
That would be great. And, one of the questions that I always have, and I've learned so much from you at Spear, from Jeff, from Jeff Rouse. I mean, actually, I've learned more from you and Jeff Rouse than ever Jeff Horowitz, but I'll just go ahead and throw Jeff's name in the ring anyways. But
tough crowd.
So many things that I've learned over the past years. I'm kidding, Jeff. I've learned some from you. Jeff Rouse, that is. But there's so many things that I've learned over the past years as I start following this sleep and TMJ pathway. I think that we have a huge disconnect in dentistry, and I apologize to anybody that I offend by saying this, but how do we champion orthodontists and have them become more understanding of this? I mean, I love my orthodontists that I work with, and they even admit, I wish I knew more about that than I did. I
think we bring it to them, just like I said before.
Yeah,
we work up the cases on our end and bring it to them. That's how it's going to change.
Yeah,
it's the only way, because it's not going to happen. It's the same with oral surgeons. It's the same with oral surgeons. They're not. It makes no sense for us to expect that they're going to do what we want them to do.
Yeah, I just really, I get it, and I hear that. I wish there was more that we could do. I wish that you could go speak to every residency that there is, and just get you and Horowitz in there and just really help them understand what we're trying to accomplish, because there's a disconnect, and I hope that it will change. I've noticed that there's been a lot of change in my 24 years of practicing dentistry, and I hope that trend continues. I just hope that it moves along at a little bit of a faster rate.
I will tell you confidently today, there are more dentists imaging jaw joints than at any time in the past, and there are more young dentists looking at joints than they ever have in the past too.
Yeah,
so I think airway is kind of dragging him into it, to be honest with you.
Yeah.
Yep.
I think that's exactly what happened, Jim.
That's exactly what happened. I said that a long time ago that was going to happen.
Yeah.
Because once you start taking a CBCT, you're going to see a bad joint.
Sure.
Yeah, it was great. I was lecturing to empty rooms for airway, and then those got filled up, and then all of a sudden the empty rooms that I had for TMJ started filling up after that, because they realized that they didn't know anything about the joint, and you can't reposition a mandible and not expect that there's going to be no implication to the foundation.
You cannot do sleep today unless you can diagnose joints.
Absolutely.
No one says that out loud. I'm going to say that.
Oh, I said there was a large company that wanted me to teach sleep for them, and they were teaching orthodontics and TMJ and sleep to people who knew absolutely nothing and doing it in such a poor fashion that I said, there's no way. You can't just do this. You can't give them an orthodontic functional appliance and have them have no background in ortho or the foundation and what they're doing when they're changing these skeletal relationships. So
I think, it's interesting.
It is good that we've gotten here.
I think what it really shows us, though, is that we have deficits at the mandibular and maxillary level on more patients than we previously assumed.
Mm-hmm.
That's what I think is the unnerving part of this whole discussion. Because, the patient we just talked about, all of a sudden now, that's a lot of big asks for a patient.
Mm-hmm.
And not everyone's going to be able to afford it. Not everyone's going to be motivated to do it. So where does that leave us? It leaves us working in a compromised foundation.
Mm-hmm.
And therefore, we have to be able at some point to understand our risk factors so we can communicate them effectively to patients. But that's the reality of the situation. Not everyone's going to go get a 3-piece LaFord, a lower double jaw. I mean, those cases aren't, I'm not saying people aren't going to do them. But, it's funny. Those get talked about so much today. And I ask people, now, how many cases have you done like that? Oh, I haven't done any. Okay. Yeah.
Well, let me ask you I'm going to ask you a rhetorical question because I know the answer to this, at least from my practice and having watched it. And I hope that the listeners and viewers I hope this helps you understand how much of an issue this is and that it's really not understood by a lot of the oral surgeons and the orthodontists out there. How many class 2 corrections have you seen completed, Jim, by orthodontists and God forbid with a sliding osteotomy where the joint position was left in a what I would call pathologic position or in an improper position because they were focused on correcting the class 2 dentally, or they did the sliding osteotomy, leaving the condylar position off of the disc. It's incredible. Your wife, Lisa, does orthodontics in the office, and fortunately, she's been able to be along for the ride with you with the TMJ. But how many cases have you referred out in the past that you've seen them come back and the class 2 was corrected dentally, but they're still in a foundational crisis?
I'm going to change one word that you said. You said joint position. I'm going to substitute joint condition.
Absolutely. Good with that.
I think the structural alteration occurs before the class 2 occlusion occurs. And therefore, all we're doing is chasing teeth. Here's what determines how well a class 2 finish is going to hold up. It's going to be the stability of the bone. The less stable the bone is, or the less the bone grows, the more difficult it's going to be able to maintain that class 2. So those are the ones that become difficult. The small condyles, the eroded condyles, the short ramus lengths, all the same cases we're talking about in the airway world. You know what I mean? Now, I will tell you, I've been, since Mark talked about class 2 occlusions in the late 80s is the first time I really understood why class 2 occlusions were more risky. I always thought it was genetics. You got a bad roll of the DNA, the genetic DNA dice. And
wait, you were alive in the 80s?
I was alive in the 80s. I was. Yeah. Believe it or not. So once I started imaging class 2s, it became really apparent. The reason why they were a class 2 is because I originally thought they lost vertical dimension. I've changed my thinking now to think that they never achieved vertical dimension. I think most of the tougher cases we see today never got there. I don't think they grew and then broke down. I don't think they ever got there. That's what I mean. It happens earlier than we think.
Mm-hmm.
Absolutely.
I'm convinced of it, which is the same stuff with airway.
Yeah.
You know, but all of a sudden now you're not supposed to treat the young patient. You know, we talked about this earlier. This is the only orthopedic joint in the body that isn't treated as it's growing and it's degenerating.
Yeah.
And what have the radiologists said to us about the conditions of a lot of these MRI image joints that, you know, you and I have both heard this, that a lot of radiologists say that they have never seen any other joint in the body that has such conditional problems in young people as the temporomandibular joint.
Tom Preddy is the radiologist I've used for the last 25 years. Tom's a great guy. He will tell you without a doubt that the jaw joint is the earliest joint in the body with the severity of injuries that it has. And you generally don't see that level of injury in orthopedic joints till people are in their 50s and 60s on the rest of their joints.
Yeah. I think that's a great place to close on. We've hit 9:30, and Jim, we could sit and sip a bourbon or sip anything for that matter. I could sip water with you and do this all night. And I know everyone else listening
Me too.
could do the same, but
this is so much fun, guys.
Yeah. But on behalf of all the dentists in the know, we just want to say thank you for being a friend to us, for coming on again, for sharing your knowledge. And Jim, real quick, do you want to can we give a shout out to your study club for anybody who might be interested? Sure. or anything you want to tell them how to get in touch with you?
Chicago Study Club program. I started it a couple of years ago. We meet twice a year for 2 days, once in the fall, once in the spring in Chicago. And it's restorative and joints. I do it with 3 other dentists. Kurt Ringhofer is a dentist who practices in Orland Park, which is pretty close up to me in Chicago here. He's a member of the Restorative Academy. Seth Atkins is outside Dallas. Seth is a digital dentist whiz. Young, understands technology. And then Drew McDonald is an orthodontist who is cutting edge ortho in growing patients. So it's the 4 of us. We'll bring in speakers. We'll do days ourselves. It's a great study club. If you want more information, email me at jim@mckeedds.com.
Awesome.
I'm going to put that in the comments.
Yeah, for sure.
Hey, Jim, Jeff thanked you for being friends of our show, but as we close, I just want to thank you for being a friend to Jeff. I mean, he really needs that. He needs that warm and special touch. So, yeah.
I've been called special before.
Yeah. As we close, though, I just want to say what an important topic. Thank you again so much for being here. Thank you for enlightening us. I'm going to put the email address in the comments below, and I hope that some people decide that they want to focus on the joint and the restorative aspect of handling the joint appropriately. And just thanks again. It was a great night. Really appreciate it.
Well, thank you guys so much. It's always great to be with you guys.
Yeah. Well, we think the same thing.
All right. Thanks. Great seeing you guys.
Good night, everybody. Thank you very much.
Good night, everyone. And that wraps up another podcast for Dentists in the Know. On behalf of Dr. Jennifer Bell, Dr. Chad Duplantis, and myself, remember that we've got a great profession, so let's make it a great day, Dinks.